So yeah, thank you, Katja, for our introduction. So today I'll be discussing some topics about establishing trust between the new and emerging AI technologies and how you can really do that yourself as well. So next slide. So I'm discussing really this topic because the integration of AI technologies in healthcare is really rapidly evolving in the last couple of years. And I think it's really crucial for all healthcare professionals to understand how to evaluate this new AI that come to the market. So my role also as a technical physician within Delft is also to ensure that the AI models fit within really the clinical practice and really can be used to solve problems and affect the clinical outcome. So today I will be sharing some insights on the evaluation of emerging AI technologies and also share you a little bit about the journey that CAT4TB has done to really put it into perspective. Yeah, we can go to the next slide. All right, so it will be three main topics. So some practical considerations for integrating new AI solutions, also going over some of the topics that Bram really discussed. Then secondly, reviewing evidence for new AI solutions from some tools for yourself. So everybody can use to build a trusting bond between you and the AI. And then CAT4DB, a decade of building trust. Next slide. All right, so first start off by the practical considerations. Next slide. And I think that for yourself is really you have three main questions that you have to ask yourself when you see something that might be interesting. And first off, and also Bram really looked at this, is the modality, or in this case, often X-ray, the right modality to use for the disease? Because AI is just an extension of the modality used, some limitations and challenges that initially apply to the X-ray, for example, would also apply for the AI. So for example, if you had an AI that would actually try and do a diagnosis of asthma, you could have to think like, is X-ray actually the tool that you use to make the diagnosis asthma? So you have to take this in consideration. And secondly, and I think this is really important, is where do we put the AI in the patient journey? So for CAT4TB, it becomes quite clear that we put the AI before the confirmatory test, in which we send people with a high CAT4TB score for a gene expert, for example, and let the others go back home. How does the new AI really come into play when we put it into our screening program? And that's where the third point comes in. What do we do with positive cases? I think it's very important to have a clear plan for managing positive AI results, as it includes determining the next steps. Are there additional diagnostic tests, referrals to specialists, and treatment options? So there's all kind of logistics around it that you might have to organize if you have a positive case. Next slide. And taking really everything into account, we really want to focus on three main topics because we're in the screening program. So we want to keep it simple. We want to have actually an increased performance of our AI. And we also know that radiological features are not really diseases. Next slide, please. So really how our approach of CAT4TB is currently is that we want to keep it simple. So we have three scores, which were already shown by one of the previous, by Guido actually. First one is the one that we all know is the TB score. So it's trained on a bacteriological reference and really predicts whether a patient will test positive on a bacteriological examination. And secondly, we have the abnormality score. It's trained on a radiological reference and includes and detects lung field abnormalities. This also includes effusion, atelectasis, pneumothorax, nodules, and much more. But we really put this all into one abnormality score. And lastly, we have the cardiothoracic ratio, which indicates, of course, cardiomegaly. And we really combine all these three scores because we know that in a screening setting, overloading patients or users with information also affects and complicates the whole patient journey. Next slide. Yes, and I think Bram also shortly touched onto this, but I got actually a different article to show it. And I think also this is what we see with most AI now in the field, is that we see an increased performance if you look for general abnormalities. So combining everything into one score actually. And we can see that also here in where we have an increased performance compared to the other nodule opacity and pleural effusion detected by this specific AI. Next slide. And lastly, and I think this is indeed also very important to consider, is that diseases are really something different compared to the radiological features. In this sense, a radiological feature could help diagnosis of a disease, but are very often non-specific. So in the case of consolidation, for example, there are a lot of diseases that actually show and have consolidation in a chest X-ray. However, having consolidation does not mean that we have to treat the patient for this specific thing. It could still be something that does not have to be treated, or we could have various different treatment options. Next slide. So I think we really want to be careful, and we really put an emphasis on that we are in the screening setting. And I think this is really important because every false positive that we do send through actually wastes resources. And we know that we're in a resource limited settings. This does also affect the amount of people that you can reach. So we want to focus really on outcomes and AI that impact the patient treatment. Next slide. All right. So, but still, we are also generating new AI and much more AI are coming to the field. So I also want to give you some tools about how to review evidence yourself and see if it actually matches your patient population and your setting. Next slide. So first off, and I think, reviewing articles can be very daunting, but this are just some easy tricks to see whether the results would actually also be applicable for you. And that is really to look at the authors. So who are the authors? Who wrote it? Can we see from what institutions they came? And are there any conflicts of interest, which should often be declared in a paper? And one also important thing to note is that we also have to look at peer-reviewed articles, where the content of the article is often reviewed by other independent researchers. Next slide. All right, and I think this is from the same paper that also Bram showed. And I think we have to always look at what population they use for their study. And can we also apply it to our own setting, or do we have to take that into account when we interpret the results? So this study was conducted, for example, in a low TB burden country, Germany actually, and they only used abnormal chest X-rays included in the study. So taking these two factors into account, does it actually apply to the screening setting in which we maybe want to use the AI? Next slide. And lastly, I think we also should always look, of course, at the results. I think that, people can often say, look, our AI works very great, but we really have to keep looking at the numbers. And in this case, we always have these 4P statistics. I think most of the people know sensitivity and specificity, and these are almost always provided. But I think, as Rodney also said, is that the positive predictive value is also very important to really see what kind of impact an AI would have maybe in our setting. So as a result, as an example, in this paper, you can see that the nodule AI has quite an all right performance regarding sensitivity and specificity, both higher than 85%. But when we look at the positive predictive value, we only have 11%, meaning that if you have 9 people who test positive on a nodule, only 8 out of 9 of these patients will actually not have a nodule in the chest X-ray, meaning that you would only have 1 positive case and 8 cases actually maybe wasting resources during a follow-up. And I think we should really take at these numbers to look at how it will affect maybe our setting. Next slide. And I think besides really delving deep into the research, we should also look at the manufacturers. So for this example, also Delft, as we also have are responsible by providing our users with information. And we often put these in these extensive manuals and to give it a user-friendly experience to look at how the product is used, but also what limitations and contraindications are also there. And I think that if you want to use new AI, you should always approach the manufacturer and ask the use cases and the limitations of the product. Next slide. All right. And also, yeah, let's go to the last chapter where we really also compare and see how Cat4TB did in this space and how we actually build trust with our users and with the WHO over the last decade. Next slide. Thank you. Yeah, Cat4TB really started already in 2007 with its first prototype, meaning that it already started over almost 20 years ago with its first implementation in 2011. Cat4TB was CE certified in 2015, but still it took 6 more years before the WHO endorsed Cat4TB screening, meaning that it takes a lot of time before we actually know whether a product is really working in all different kinds of settings. But not only time will do that, but also really a variety of different publications. Next slide. So Cat4TB, there are over 110 papers published in peer-reviewed journals, not only from one country, but all over the world. In at least 25 different countries have validated and published independently also about Cat4TB. The product has been used in various types of screening settings, for mass screenings, prisons, migrants, but also from active case findings, and tested in various comorbidities. So we know that this is not only working with patients without HIV or diabetes, but it's working in a diverse patient population. And I think this really gave also the WH the trust that the Cat4TB screening could be entrusted and recommended. Next slide. And lastly, I think it's also our job, and I think we also really proud ourselves to transparency. So as Delft, we also try to be as transparent as possible, and we also do this with the following topics. So we try to maintain research independency as much as possible. So independent researchers publish about our limitations, but also about our strong points. We promote and share these independent studies, highlighting both strengths and limitations, and provide users with easy access to the evidence. So you really can ask any of my colleagues for a paper whether it matches your screening setting, for example. Well, we organize these kind of webinars to support knowledge sharing, of course. And lastly, we offer a service where user can also test the product and see if it also performs according to their standards in their own patient population. Next slide. So really to conclude is that Cat and Delft really pride itself on careful implementation to really ensure benefit. We promote external validations and think that research is very essential before adopting a new and emerging AI. And in general, we think that transparency in good clinical practice should also be maintained by manufacturers. Next slide. All right. Thank you everybody for coming, and then I'll pass on the word to Katja again. Thanks.